talk about the organophosphate poisoning. Again, I'll talk about a case scenario first. A 45-year-old farmer was found in a semi-conscious state at the roadside, and he had some difficulty in breathing with copious amounts of white-colored secretions and muscle twitching around the mouth. And he was diaphoretic with a GCS of 10, and the pupil size was 2 with a blood pressure of 90/60, and the pulse rate was also 40. Now the respiratory rate is 22 minutes with a saturation of 86% on air. Now can one of you all say, because I have told about this earlier, we have talked about in the topic also, but according to the toxidrome, what sort of toxidrome this patient is having? It's quite obvious according to what we have already discussed. Can one of you say? It's a cholinergic toxidrome. Yes, thank you. So, but when a patient like this present to our ward, we have to actually go through several differential diagnoses. It can be either pontine hemorrhage, it can be an opioid overdose, it can be organophosphate poisoning, it can be epilepsy also. So all these things are possible in this type of a patient. So there are a few things which can explain all the differential diagnosis, but everything the patient is having actually can be explained by the organophosphate ingestion. So please remember that there are other differential diagnoses also that you have to entertain if this sort of patient comes to your ward. Now again, when you're going through the suspected patient with OP poisoning, again look to ABCD assessment and resuscitation. All the things are necessary has to be borne in mind, and then you have to think what the patient must have taken, and you can apply the toxidrome approach in this case scenario too. So this is very easy. Again, a patient is somnolent, drowsy, blood pressure, pulse rate and temperature is actually low with low temp respiration, also pinpoint pupils and wet skin. So the cholinergic toxidrome applies. And as I earlier said, there can be toxicological causes and non-toxicological causes in this case. So in this scenario, CT brain is actually warranted. Okay, then you go for the analysis of the toxidrome, and then you suspect cholinergic toxidrome. So in this case, please remember, even before you try to intubate the patient, you need to give atropine. This is the treatment, because what happens if you don't give atropine at the correct moment, the patient is actually having a lot of secretions. You will not see the trachea. That's for one thing. And the other thing is patient's pulse and blood pressure is low, and you will be maneuvering the neck for intubation, and that might further increase the vagal tone, and it will reduce the pulse rate as well as the blood pressure. So what you should do, you should first atropinize the patient. As soon as you put 2 wide bore cannulas, you start giving atropine, and then only you try to intubate also. So that is the thing that you have to be doing when you are in a peripheral hospital. So load the atropine. Even if you don't have time to intubate, you can bag ventilate and still, start giving atropine at that moment. So, so the next best step in the immediate management of this patient is not the induction of vomiting, not the gastric lavage, not the activated charcoal. This is the atropine. Okay. Now, the one thing actually peripheral hospitals are doing is they think that the induction of vomiting is as synonymous with the gastric lavage. Please, I actually, because this is seen by all over the country, and I know the most of the doctors are actually watching this. So please don't induce vomiting. So it's a contraindication, and it's not synonymous with the gastric lavage. So what you have to do is, if the patient is actually having a GCS of less than 10, you have to intubate the patient first and protect the airway, and then do the lavage. Otherwise, what will happen is you will be doing more harm to the patient. Patient will get aspirated, and that will give rise to dire complications. So please remember that this is one of the highlights that I should, I'm trying to highlight this point over and over again, because this is happening everywhere. So the correct answer is giving atropine, which is the antidote, and it is life-saving measure to prevent cardiac arrest and the respiratory arrest. So now again the important slide, the indications to start atropine. So if the systolic blood pressure is less than 80 and the pulse rate is less than 80, wheezes and crackers, small pupils and excessive sweating in the axilla. You don't have to have all 5, okay? You don't have to have all 5, but you need to start treating the patient as soon as possible, as I said previously. So how are you going to start treatment? 3 to 5 vials as a bolus. So it can be either 3 or 5, because depending on the clinical situation of the patient, you can decide on what to give. So 1 vial is actually 0.6. So 0.6 into 5 up to 3 milligram bolus you can give. All right. So then you double the dose at regular intervals, every 5 minutes until the patient is fully atropinized. So if you have started with 4, then you give 8, then you give 16. So until the features of atropinization is elicited. So what are the features of atropinization? It has to have a clear chest, heart rate more than 80, pupils no longer pinpoint, dry axillae, and the systolic blood pressure more than 80. Again, as I told you, you don't have to have all 5, all right? So the clear chest, heart rate more than 80 is enough, because pupils anyway will take longer time to dilate, and the blood pressure also fix a little late sometimes. So these things will actually be very useful. But please remember, since there are nicotinic effects, there can be tachycardia. All right, even if there's OP poisoning, there might not be bradycardia. So you will think atropinization is actually achieved. So please remember, always check for the lungs as well as axilla if you are in a doubt. Okay, sometimes the patient is actually tachycardic, but the patient is under atropinized. Okay, so that is also very important to note. And then, as I said, while you are giving this treatment, you review the parameters: 30 minutes for 3 hours, hourly for 6 hours, 3 to 6 hourly for next 24 to 48 hours. So this is also important. Now, please remember, once you have given the boluses, you can't stop atropine. You have to start an infusion. So how are you going to start the infusion? You calculate the amount of atropine given during that period, and then from that you take 1/5. All right. So if you have given 100 milligram atropine, so you take 20 milligram and put it as an infusion. Okay. So so this is what I have actually emphasized here. Start infusion using 20% of what was given as boluses every hour. And then you keep reducing the rate every half an hour, depending on 3 vital parameters: lungs, heart rate, and blood pressure. Now, while you are doing that, if the atropinization is lost at any point, if the patient is again having crackles in the lungs and blood pressure is low and pulse rate is low, you need to again give a few boluses. Now, after you have given the few boluses, if the patient has achieved the atropinization, then you have to calculate the boluses again, and from that take another 1/5 and add to the existing infusion rate. Okay, so that is how you continue the infusion. All right, so this is what I have to actually emphasize. Now, again, when the patient is atropinized, you will get features of anticholinergic toxidrome. You have to be careful about that also. The earliest sign might be patient is actually very hallucinating, hallucinating and very agitated and combative. So, and the pulse rate and blood pressure goes up quickly. So then if that happens, you can reduce the infusion, or sometimes you might have to stop it and restart. Okay, so that is also important. So again, I have to tell you this. The gastric lavage is very important. Although the book says we can, we'll be doing on the gastric lavage within 2 hours only. If the patient has taken a large dose of any substance, then gastric lavage, if not contraindicated, you have to do it within 6 to 8 hours. It will benefit. Because we have seen clinically, we don't have much, symptomatic, we have only symptomatic care. We don't have antidotes, we don't have any high treatment methods in a third world country like ours. So please do the gastric lavage, as time is brain, time is muscle. In toxicology patients, time is life. So therefore, please do the gastric lavage, especially if they are in a peripheral hospital. As I said, please protect the airway and do the lavage. So if if the GCS is actually more than 10, it's okay. If it is less than 10 in a toxicology patient, they can't actually maintain their airway. There are a lot of other things also comes in to play. Therefore, please intubate. You can always extubate, and you can ventilate the patient within within the ward also. Sometimes for few hours you might have to, and then you can extubate little later. So please don't hesitate to intubate and then protect the airway and do the gastric lavage. So that is important, because otherwise you'll be flood in the lungs. Okay. So that one important point that I wanted to highlight. And then you might ask, why not PAM? Okay, so PAM is actually, there are no good studies to compare the survival benefits, because there are no survival benefit of giving PAM. That's why we are not actually, at the moment we are not giving PAM. But if you are giving PAM, you have to give it atropine. Atropine must be given before PAM, because it might worsen the muscarinic mediated symptoms. And again, atropine is usually ineffective in neuromuscular dysfunction. As I said, there can be tremor and fasciculation. These things will be reduced with PAM, and it is good for the nicotinic effects. And again, it has to be given within 48 hours of poisoning. There's no point of giving it later on. But since I said that there's no survival benefits, which with proven literature, that's why we are not giving the PAM at the moment. Okay, the next comes is the identification of the intermediate syndrome in OP poisoning. Usually it occurs between day 2 and 4, and usually the neck and proximal muscle limb weakness will be the evident, and you have to check this with one breath count. That is the one which can be done in the bedside, as well as please check the proximal muscles by asking the patient to raise the head up while you are pressing down the forehead. Because if you just ask the patient to please get up, they will use the trunk muscles and then try to sit up. That is possible. So, but real neck muscle weakness can be checked only with the while you are pressing down, asking the patient to get up from the bed. That is the best thing. And then you can do this spirometry also to get an idea if the facilities are available, and they usually drive from respiratory paralysis. So if you are in a doubt that the patient is going into proximal limb weakness, please don't hesitate, electively intubate, because it is important again, rather than waiting for the emergency ventilation, electively intubate and ventilate. And there's this organophosphate, which is actually lipid soluble, called profenofos, and there are so many others also. If the patient has taken profenofos, it takes longer time, because it will get deposited in the fat and usually slowly released into the system. Therefore, symptoms will last longer. The patient might need atropine infusion for a longer time. Sometimes even for 7 to 10 days, we might have to give the atropine infusion, especially the people who are working in the critical care setup. Please remember, the intermediate syndrome also can occur a little late, not the day 2 or 4. Okay, so that is actually proven. So again, succinylcholine must be avoided, as it may prolong the paralysis. So I think I have come to the end. So this is these are the things that I wanted to highlight. The gastric lavage, even the patient comes within 6 to 8 hours. If it is a large dose, please do the gastric lavage, and if appropriate, give the activated charcoal, and please give atropine before you attempt even intubation, and give the proper dosing. As I said, boluses, infusion has to be given accordingly. And thank you very much.